this is Chapter 6 lecture video part 2. Chapter 6 is addiction across the lifespan. So we are going to take a look at, the later part of the lifespan. In the first lecture video, we covered Erik Erikson stages 5 and stages 6. In this video, we are going to cover stage 6 and stage 7, stage 8. Moving forward with that, let's start with stage 7, which is generativity versus stagnation. So we're looking at middle adulthood is the age range that we're focusing on right now. In this stage, the generativity and stagnation, the tasks that we are looking at is, what are people in middle adulthood? What are the tasks that they are trying to complete? So they want to feel that they are needed in this age range. They want to feel that they have made a contribution to others. They want to leave something behind. That is really important. So during this age range, they want to feel as if they've left something behind for maybe a child, family, friends, whoever, life itself. They want to feel like they've left something behind. And they're also thinking in terms of, while we're still able to do these things, I want to be able to do whatever it is, travel or, different things like that. I want you to take a moment to think about somebody that you know in middle adulthood and think about the different, situations that they face, the different stressors that they face, or, what is that person like? Do they use? Do they not use? Are they working towards something to leave behind? What types of things do they enjoy doing or like to do? Personality changes can occur through one's life. So your personality can change at any time and change throughout the duration of your life. As we've discussed, longtime users of addictive substances often discover pleasures other than their favorite substances and begin to connect with others in a new way and in more satisfying ways. So that's something to think about too. Sometimes the addict just longs to have a normal life, whatever this normal life may be for them. But to them, that normal life isn't chasing around drugs. So they're longing to have something that maybe you and I have, whether it be going to school or getting up and going to work every day, whatever we consider to be normal, that is something that they too are chasing themselves. Again, I don't like to necessarily focus on what normal is because, who are we to define what normal is, but that's what they are looking for. In middle adulthood, at this stage, the addict may have a family to care for, or someone else to be loving toward. If their family is still in the picture, or maybe their family is no longer in the picture because of their use. And maybe, some of these middle adulthood people are vets too, something to keep in mind. The prevalence of substance use, we've seen that heavy drinking and drug use in teens and young adults might be high in their 20s, but it starts to trail off as they age and they're taking on different life responsibilities. So you almost mature out of that use that you were doing around age 20 or, whatever age it was. So what jumpstarts this type of recovery? Negative consequences start to dawn on a person. They begin to substitute dependence. And maybe they join new social groups. So what once was cool with a particular social group is no longer cool with another social group. So that's something, that could help a person get out of addiction on their own. The treatment field has overstated the difficulty of overcoming addiction because their experiences has been, with people that, have had difficult times. Those who have sought treatment, perhaps, they've had more severe times trying to overcome their addiction. We haven't paid enough attention to context. For example, students who binge drink in school and then they go out and get a job. Vets returning home from overseas addicted, but they recover once they're back home and they're not overseas anymore. The rate of increase of substance abuse, and not the incidence, but the rate by baby boomers is double that of any other age group. And this has been so over time. Baby boomers were born approximately between the years of 1946 and 1964. This includes people who are between the ages of 54 and 72 years old, and that would be in 2018. Only 3% of these started illegal drug use after the age of 50. Baby boomers also do not seek treatment as much as other people. They think that they can deal with it themselves. So, why is it important to look at addiction in middle adulthood? What happens in middle adulthood that might be different in other age ranges? Metabolism gets slower with age. There's a lower body water content. So drugs remain in the system a lot longer than maybe they did when you were younger. Most substance-related deaths occur not in young people, but in those ages 35 to 54. This age demographic is most likely to have a drug-related emergency that ends up in the emergency room, as people are getting older. They're more likely to end up in the emergency room for drug-related issues. And this demographic, if having used for some time, are more likely to already have physical damage from the use. So if they started using when they were 12, 13 years old, by this point in their life, there may be some substantial amount of damage done to their bodies. As everyone knows, we are in the midst of an epidemic of overdoses now, particularly with opiates. So 200% increase from 2000 to 2016. One of the largest increases is in the age range of 45 to 54-year-old age group. So that's that middle age group. Some guesses as to why that age group is more popular. They're hospitalized more than younger people and become addicted to pain meds post-operation. White working class adults did not expect to lose their jobs in the recession or to be isolated. Heroin's cheap. More deaths from suicide and overdose for this age group than in any other wealthy country. So going back to some topic about vets again, so the increased risk among combat vets, because we did say that this age range might have more of our veteran population. So domestic violence in vets, both men to women and vice versa, 25% of that is related to substance use. So domestic violence in vets, helps if I could talk, 25% of that is related to substance use. Also civilian contractors for whom less help is available than to vets. Most reintegrate successfully, but many have physical injuries, brain injuries, along with PTSD. For female vets, 15% of sexual trauma may happen while they are in the military. Most social workers and other behavioral health professionals are not trained to work with military. So that's it. The military is a growing field all in itself. So some people may be specializing in working with vets. Nicotine use is very prevalent with vets, encouraged by low prices on the bases, and it's tax-free. Same with alcohol, and cigarettes may help with stress. Preventative programs are being implemented. Social workers are being embedded with combat troops. Some issues for older vets. Vets can retire after 20 years of service, so they then are faced with what to do with the rest of their lives. So, they may need to fill that time of boredom, and they may fill it with using substances. There's a lot of losses. They may lose their parts of health losses, friends, and realities of aging. Combat memories may resurface when they retire. So something they may not have thought about for 20-some years may resurface after they have gotten out. Some treatment approaches to work with vets would be group therapy, family therapy, and domestic violence services would be a good one as well. Let's talk a little bit about substance abuse among women in the middle age. Like others, middle-aged women could age out from substance use. Users of illegal drugs who are Black and Hispanic do this more than white women. But for the prescription drug users, there is no pattern of use. Domestic violence is more of an issue for women and calls for integrative treatment. We talked a little bit about that in a previous chapter. Moving on to stage 8. Stage 8 is ego integrity versus despair. So we're looking at older adults. So the ego identity is peace, pride, in our accomplishments. So we're looking back over our lives and hopefully at peace and finding pride in the things that we have accomplished over our life. So what is the alternative to this? You might be bored in retirement. You might be widowed, loss of friends, not enough money, lonely, depressed, things like that may trigger a person to use substances. People that are age 65 and over are the fastest growing age group in the United States, and that's about 15% of the population. Their substance use is also more private. or may not be as known to people, at this particular age. Alcohol and non-medical use of prescription medications and symptoms may be confused by professionals with medical or psychiatric conditions. So as a person is getting older, we may confuse those symptoms with that versus actually that they might actually be using drugs or alcohol. The impact may be greater due to age-related physiological changes as well. There are some trends in the older population that I wanted to take note of. They may drink smaller amounts at one time, use prescribed medications not as prescribed. Alcohol problems can be hidden. Some stressors, as we've mentioned before, loss of family, loss of friends, retirement, and more use for pain relief than recreational. So we talked a little bit about which drugs might be better for, pain relief, and that might be more of a target for the older population. Some substances that are used in the older population could be marijuana. Men use marijuana more than prescription drugs. For women, it's about equal. If we look at the age 65 and older, non-medical use of prescription medications was more prevalent than the use of marijuana. Valium and Xanax are very common for the older adult population. Alcohol use, 42% of those over age 65 regularly drink alcohol. Binge drinking, 65 and older, is 9%. So we still have binge drinkers in the older population. Some things to think about with assisted living and nursing homes. There are differences between those who have been lifelong drinkers and carried problems with drinking into old age versus those who are just drinking in old age, and it wasn't a problem. About 2/3 of the older problem drinkers are in this category. So long-term suffer from neurological problems, have fewer family and social supports because by this point they've probably broken a lot of their family relationships. Recently tend to have family ties, may have shame, lack of empathy. But if they enter treatment, family may bring them in, and the outcomes may be better if the family is still involved. If you're working in the healthcare setting, you will see more alcohol-related problems with your patients at admission. Some assisted living facilities have happy hours. That's something to take note of too. They're bringing back that social aspect of drinking. And I don't know how they monitor their alcohol use in an assisted living program for that, but we've seen that older adults account for a lot of the healthcare admissions. Of those who seek drug and alcohol treatment in the older population, more so than not, more are not married. They don't have income beyond Social Security, and alcohol is most prevalent than heroin or than cocaine. Those who started using recently would be prescription medications. 25% have been using prescription medications, and that is increasing for the older population. Most older adults do not use treatment. They are not involved in the court system, so they don't get mandated treatment. They may be less likely to get the help that they need because they don't see it as a problem or they haven't committed a crime to be court ordered. Or they're alone. Maybe their family isn't around or people have passed away, so their use is able to be better hidden because they're not really interacting with a lot of people. So those are some reasons why they may not engage in treatment. Some biological considerations for the older population. People 65 and older comprise about 13% of the population, but account for 30% of the medications prescribed in the United States. 1 in 4 have a psychiatric diagnosis and are apt to be using psychotropic medications. As we have seen, psychoactive drugs have stronger effects on the elderly population. You may get high or drunk quicker and have a lower tolerance than a younger person. Again, those body changes could have an impact on that. Death due to the effects of taking multiple drugs is higher than any age group for the older population, and they're more likely to be taking prescribed meds that interact with illegal medications or alcohol as well. So we have the drug interactions that we have to be aware of with this population too. More than 80% of emergency room visits by older adults are related to adverse drug reactions. You might have more GI issues, hip fractures, brain damage, stuff like that. Because of the combination of smoking and alcohol use, you might be seeing more lung problems as well. Some treatment interventions are some things to keep in mind when you're talking about treatment types of interventions. Stereotype, the young won't listen and the old won't learn. And neither of those is true. But some things, the stereotypes may prevent a person from getting the help that they need. Should older individuals be treated with their own kind? That could work both ways. If we have just an older group population, they could focus on the issues that are particularly related to older adults, but maybe they could be more helpful to some of the younger adults in a group as well. Some like to be with similar age individuals and some like a mixed age of individuals. It just depends on the person. Some hearing issues could dampen participation. They may be hard of hearing or they may not be able to understand. Fewer treatment programs can afford separate programming, so that's something to keep in mind too. Not a lot of facilities offer those specialized groups. Remember, older females can experience more shame, so avoid use of alcoholism, use drinking problem, rather than labeling a person with alcoholism. You could focus on health issues. Watch out for countertransference, feelings about one's own parents and grandparents. So your feelings may be kind of being put out onto your clients that you're working with or the people that you're talking to. Motivational interviewing is the only strategy that has been found to be effective with the older population. You definitely probably don't want to use a confrontational approach with someone that is older. By this point in their life, they may be kind of set in their ways, and a confrontational approach is less likely to be effective with them. HALT is something that maybe, you may be able to work with the older population. Don't get too hungry, angry, lonely, or tired. That's the acronym HALT. And if you know solution-focused treatment, remember that you don't have to be the expert on them. They know themselves better than anybody else. So you don't have to know them, but they know them. So solution-focused therapy would be a good approach to work with too. At this age range, we have to take into consideration loss and grief. Learning to grieve effectively is important. Types of guilt. There might be survivor guilt, complicated by helplessness, ambivalence guilt. Caregivers get worn out with things. And the last topic that we're going to cover in this lecture video is spiritual healing. There may be more of a sense of spirituality at this stage of life. Some reasons for that may be mortality, seeking meaning for their life, or guilt. Guilt is a big one, and forgiveness. Robinson study in 2011, whether a person was in AA or not, more of those who recovered had increased their spiritual practice and were able to forgive themselves. So with that being said, raise the issue of spirituality. Bring it up when you're working with the older population. Help your clients who want to seek spiritual connection do so. Help them find a local church. Help them find that AA or NA meeting that's local to them. Whether it be prayer, yoga, whatever traditional religious affiliation that they want to be a part of. Refer to a priest, rabbi, pastor, whoever it is. Help those people get connected with their spiritual connection that they need. Praying may help reduce dangerous alcohol use. And mindfulness meditation can reduce the risk of relapse following treatment. Mindfulness targets 2 triggers of relapse, craving and negative emotions. So mindfulness is definitely good with that. And if it's something that you don't feel you're comfortable working with when it comes to spiritual healing, call somebody else in or refer them out to somebody else that may be able to better assist them with that if that's not something that you're comfortable discussing with them. But definitely some things to keep in mind when working with the older population. So that is chapter 6, and that was talking about addiction across the lifespan. So thank you, and stay tuned for the next chapter.